Hey everyone, welcome back to the channel. If you're new today, we're diving into a topic that's crucial in rheumatology and internal medicine. How do you diagnose rheumatic diseases? Whether you're a clinician, a student, or just someone curious about how these complex autoimmune disorders are identified, you're in the right place. Let's get into it. Diagnosis starts with the foundation of medicine, a comprehensive clinical evaluation. That means taking a detailed patient history, and I mean detailed. Ask about when symptoms began and how they've evolved. Was it sudden or insidious? Do they come and go or stick around? What joints are affected? Is it symmetric like in RA or asymmetric like in psoriatic arthritis? Morning stiffness lasting more than 30 to 60 minutes can hint at inflammatory arthritis. Ask about fatigue, daily limitations, or systemic symptoms like fevers, weight loss, or night sweats. Extra articular clues matter. Think rashes, dry eyes or mouth, cough, shortness of breath, or urinary changes. Don't forget family history, environmental exposures, and medications. Things like smoking or silica exposure can tip you off. Next is the physical exam. This includes a thorough joint assessment, looking for swelling, warmth, tenderness, deformities, and limitations in movement. But rheumatic diseases don't stop at joints. Inspect the skin, eyes, mouth, heart, lungs, and neurologic function. You'd be surprised how many clues hide outside the musculoskeletal system, like malar rash in lupus, crackles in interstitial lung disease, or livedoreticularis in vasculitis. Lab work helps confirm your clinical suspicions. Start with inflammatory markers, ESR and CRP. Then dive into the CBC for anemia or leukopenia. Look at autoantibodies, rheumatoid factor and anti-CCP for RA, ANA, and its subtypes for connective tissue diseases. Want to test for lupus? Go beyond ANA. Check anti-dsDNA, anti-SM, or low complements like C3 and C4. For myositis, look for CK or aldolase. For vasculitis, ANCA testing is key. And don't forget the basics like urinalysis. Proteinuria or hematuria could point to lupus nephritis or vasculitis. Imaging gives structure to your findings. Start with plain X-rays for erosions or joint narrowing. Use ultrasound to detect synovitis or increased Doppler signal. MRI shines in early sacroiliitis, myositis, or soft tissue involvement, while CT scans are great for evaluating lung disease or vasculitis. When you're faced with a swollen joint, especially monoarthritis, synovial fluid analysis is critical. Look at color, clarity, WBC count, crystals like MSU or CPPD, and always rule out infection with gram stain and culture. Sometimes you need to go even deeper, literally. A biopsy can help diagnose lupus nephritis, inflammatory myopathies, Sjögren's syndrome, or cutaneous vasculitis. It's not always necessary, but when it is, it's often definitive. Each rheumatic disease comes with its own validated classification criteria, like the 2010 ACE-ULAR for RA, 2019 ULACE for lupus, CASPR for psoriatic arthritis, ASAS for ankylosing spondylitis, and others for systemic sclerosis, myositis, and more. These criteria don't replace clinical judgment, but are powerful tools to support diagnosis. So there you have it. Diagnosing rheumatic diseases is like solving a layered puzzle. It takes a sharp history, a focused exam, smart use of labs and imaging, and sometimes even biopsies or formal classification criteria. If you'd like a diagnostic algorithm or a downloadable PDF summary, drop a comment below or check the link in the description. I'm happy to share a clinical cheat sheet that simplifies all of this. Thanks for watching. Don't forget to like and subscribe for more high-yield rheumatology content, and I'll see you in the next video.